cancers, and the answer is yes, it can. Any white blood cells fight germs in a lot of ways, but one of the ways they fight germs is by secreting these little Y-shaped antibody proteins to fight germs. Any blood cancer that comes from one of those cells can make those antibodies, and any white cell disorder that makes abnormal antibodies, the antibodies can fold into amyloid. So we see amyloid secondary to different forms of lymphoma, to chronic lymphocytic leukemia, and it adds, intense complexity to the situation. We'll see patients diagnosed with amyloid appropriately, but where the target for the treatment becomes confused. And people don't know, people will say, for example, oh, this person has lymphoma and amyloidosis, and they'll try to give medicines for both, not realizing that it's the lymphoma cells that make the antibody that becomes the amyloid. So amyloid is seen most commonly related to multiple myeloma when it's a blood cancer, but lymphomas of many types, leukemias of certain types, can also provoke the illness. And again, those are patients that have a lymphoma, they're being treated, and all of a sudden they're not doing well. And doctors are scratching their heads and trying to figure out what's wrong, and the kidneys aren't right, and the heart isn't right. And then before you realize what's going on, it's often very late. So that's all part of education.
Would you recommend anybody that's suffering from any blood cancer disorder be screened for amyloidosis?
So it's a tricky question because a blanket statement about screening for specific people with an illness is tricky. What is best is if you have a doctor that sees a lot of that illness and is therefore aware of some of the potential complications, amyloid being one, but there's a half a dozen others that are associated with multiple types of lymphomas. So expertise does matter. And you want someone who, it's not, the fourth case they've seen in a decade, because, the book only tells you so much. Experience is valuable.
Thank you.
I know of someone who passed away from amyloidosis like in hours. They didn't have anything wrong with them that they knew of. They were fine, and then... So that can happen also?
When amyloidosis affects the heart, in particular,
that's what it did.
The heart is an interesting organ. It's an engine, it's a muscle, but it's also an electrical organ. It has electrical activity that keeps everything regular. And when you stick amyloid, waxy proteins throughout the electrical system, you get frizzes, it gets haywire, and people can have sudden arrhythmias. And in amyloidosis, that's absolutely a major concern. I've seen patients with amyloidosis like you described, where I meet them in a hospital, sick as can be, and they don't live very long. And I've seen people with amyloidosis. I just saw a woman randomly, not even in a visit, because she's so well she doesn't come see me, who 6-7 years ago, right when I first got down to Florida after fellowship, we diagnosed her, and she was pretty sick. And honestly, you'd see her now, you wouldn't even know. And the difference in a lot of these cases, some of it's the right treatment and a little bit of good luck, but a lot of it can be traced to time of diagnosis. So that unfortunately happens way too much.
What should you look for?
Yeah, right.
So you can catch it early. What's the deal?
Yeah, the screening, the concept of screening, you would never want to screen everybody walking into the mall for amyloidosis, because as a rare illness, you're going to have a lot of negative tests, right? And it's not a good use of resources. But if you identify certain ways that people present, when people present spilling a lot of protein in their urine, when people present with a thick heart without a history of high blood pressure. Not to get technical, but there's a couple of times where people do show up in the medical system with an issue. And, many times the doctors will think of the common things and try a medicine and see you back in 2 months, and, you just get into the rigmarole of medicine. And that would be a time where when someone in your office, if there's a check, oh, look, this person has X and X, we're supposed to send off the amyloid test, And so that's kind of really what we're looking for. In terms of who to think of with amyloidosis, again, it gets technical, but it's people that have heart failure for unexplained reasons, people that have kidney failure for unexplained reasons, people that have neuropathies and dizziness for unexplained reasons, and certainly anybody that has more than one of those features.
Isn't that a little late when all that's happening?
Yeah, well, yes and no. When someone shows up in an office a little bit winded and has abnormal kidney tests, we don't want to be diagnosed with everything like 2 minutes before it happens, but the reality is you kind of have to somehow get a little unwell, in most cases, before you're going to know something's wrong. But again, that's the time when they walk into your office and they played only 9 holes but not 18 because they got a little, run down and something's different. That's the time you'd like to pick them up, and not when I haven't been golfing in 3 months because I walked, you know, to the tee and I'm winded. So there's.
What is the test?
So there's a hereditary test for the hereditary disorder, and actually it's we're running it in. We have one of the UM labs that's now being geared up to run that in-house. And the blood test is looking for abnormal antibody fragments. It's a simple blood test that's used all the time in multiple myeloma. And it's a kind of a yes/no. There's an abnormal antibody or there's not. There's not, amyloid is out. And if there is, the way our protocol is designed, they're all going to come to me or to one of my colleagues for a full evaluation. So not everyone who has the positive test will have amyloidosis, to be clear. But they will definitely require a full evaluation because you don't want to miss them if they do. And we are kind of committed to not be missing them. No one can make a promise, but that's kind of a commitment we're trying to make.
Are specialists or primary care physicians referring?
So it's a good question. Some of the primaries think about it. Some of the specialists think about it. The kidney doctors tend to be pretty good. The heart doctors tend to be so-so. You know, it depends. It really depends. You know, I've had some in the community call my cell whenever they have a case, and they're really good at it. You know, they have it on their minds. They know we have a treatment center. They're engaged in it. And then I have others that come to me because the patient found me through some network, and then, you know, I'll call the doctor, and some of them are interested to learn, and others are, oh, you know, amyloid, I know that's a bad one, you know, and it's just, so some of it is teaching people that this isn't 20 years ago, where there's nothing you can do, right? They need to know there's something to do. People don't want to look for something to tell someone they have a bad problem. They want to look for something to help people. And so we got to educate them how to look for it, when to look for it, and that there are things that we are doing, you know, in their back doors that can help people.
What exactly is the treatment for it once you discover it?
So again, part of the challenge, because the concept, if you think about the illness, right, you have something going wrong in the body that ends up with amyloid being put in people's organs. In the case of Stephen and the case of people with the blood form, the most common form, it's abnormal white blood cells that are making a bad antibody that become. So what do? We use our medicines that work in myeloma and work in related illnesses to eradicate all of the bad white cells. And when you eradicate them and you put people into remission, which is something we can accomplish a high percentage of the time, no more amyloid is formed. Now, the heart that was sick is going to take time to get better. Like if someone has a heart attack, they can recover, but that takes time. So the concept, what we can do today primarily is turn off the problem and allow the organs to heal. One of the research studies we're about to open is with a novel drug, the first ever, that will target the amyloid that's already in the organs and help try to leach it out. Now that's experimental and we don't know how well that will work, but that's a second part of the process here. But generally, we're better at turning off the disease than we are at reversing it. But again, you can see why time matters, because if someone has advanced heart failure, even if you turn it off, they have advanced heart failure. They may get better to some degree, but if someone is just carpal tunnel, right, and some mild kidney injury, that person could live out their lifetime and not have further complications. I don't want to, just as one thing, I don't want to create the false impression that amyloid is, you know, is everywhere. It's not. Now, I see a lot of it. So you come hang out with me in my office for a day, you'll feel like it's everywhere. Okay, it's not, but it is under people's noses, it's not diagnosed, and every case that's diagnosed this late is a tragedy, you know, in my opinion.
So what is the best direction for funding? Is it research into the disease? Is it improving awareness?
I think it's a multi-pronged approach. I think that better drugs are great, better awareness is great, screening is great. Probably for rare disease like this, it needs to be on all three fronts, and it's hard to say where the biggest improvements can come. You know, in terms of where do you fund, you know, it's a challenge too. You know, it's you know, there's no American Cancer Society for amyloid. There are some organizations like the National Organization of Rare Disease, and I edit their amyloid portion that distributes money to a lot of rare diseases. You know, but there's a lot of them, and they're rare. And then there's organizations like this, and there's the Amyloid Foundation is another one, and amyloidsupport.com. Those are three that I'm aware of. There's not a lot out there. And each of them, in kind of a grassroots way, often regionally focused, can make a big difference.
So I'm an OT, so do you enlist the help of orthopedists and tell them about the connection with carpal tunnel?
So our first efforts in UM are focused on the neurologists. Our second effort is the neurologists do the EMGs that will diagnose formally carpal tunnel, but we all want to work with the surgeons that do the decompressions as well. I have some colleagues in the Northeast that are waiting for us to get the screening program off the ground, and they're going to then hopefully join in with us, and so they'll do what we're doing, and we can start to get bigger numbers. And I think the efforts on the carpal tunnel side will be neurologists and surgeons, and internists as well. And then ultimately we want to approach the heart specialists, we want to approach the kidney specialists, and we want to, we can mimic the program in other entryways. And if every person that shows up in UM with heart failure without a history of hypertension or a heart attack gets the simple screening test, and if over 1,000 people you pick up, I don't even know, you pick up 5 or 10, every one that you pick up is a tremendous difference, and it's not an expensive proposition. And one final thing, I have the hereditary form is hugely underdiagnosed, as I've told you. Here's an example. I have a patient in my practice with hereditary disease who has 6 kids and 36 grandkids. Okay? Now she's in the process of figuring out how to tell her kids, but it's a genetic disorder that 50% of the offspring are predicted to have it. So here you have a whole kindred of people at risk. And if they're not aware, and if they're not diagnosed, then what will happen? They'll all go their ways, spread across the country. A couple here, a couple there will have heart failure, a couple will have kidney failure. The doctors will have heart failure. And the diagnosis goes undetected. When you know someone has the hereditary disease at age 40 or 50, there's all sorts of interesting things that can be done. In fact, the hereditary disease, to give you an example, the protein comes from the liver. And a program that we have at UM is liver transplant. You give somebody a new liver, they stop making the bad protein. And what's really cool about that, and we have a pretty good program for this in UM, the liver is healthy. It's just making a protein which over decades turns into amyloid. So you can take that liver and give it to someone with cirrhosis. We call it domino liver transplant. So every time you get a hereditary amyloid patient in, the surgeons are like thrilled because they get, it's like 2 for the price of 1. You make 2 people well with 1 liver transplant. So that family of 26 grandkids, there's things that can be done with awareness.
That liver doesn't make amyloids in the new recipient?
It will, but if you give that liver to a 60-year-old patient with cirrhosis, they're not going to live long enough to worry about the amyloid at age 110. Or maybe they will. Who knows where medicine's going.
Is there training going on in medical school now?
Yes and no. Part of the problem is, your training is only as good as your instructors. And so there's a handful of centers with expertise in amyloid and many that don't. So yes, it's part of the educational efforts, but you know how it works. You learn what you're going to learn in medical school, you go out to practice, and you get involved in what's regular, and some doctors, like some people, feel that they know more than they know, and some doctors maybe not be interested in learning, and some are well-meaning and just miss certain things. It's all of that. And it's all of those reasons. So yes, there is education. I can promise you at UM, the students are hearing more than they wanted to about amyloid, but in some centers, without an interest, without a focus, it's given short shrift.
This particular drug or drugs that you say you were using the treatment of, are they in clinical trials at this point? Because they're not out on the market,
We have
right?
some that are available, and we have some, like that amyloid leaching protein I mentioned, that are only available in clinical studies. So, and to get some of those interesting studies to UM also takes resources and connections and funding. So we're doing, I think, a pretty good job. That was one of the primary reasons I came to UM. We're doing a pretty good job in that, but there's more work to do. If a patient gets diagnosed with this disease in South Florida, they have a pretty good option at UM to be managed the right way and have access to some interesting things. But there's still a lot more that needs to get done.
How did you get interested in this? I'm just so
Love
curious.
it. I was in fellowship at Sloan Kettering in New York, and after our first year, you have to choose a mentor. And just based on my experience in the first year, I had 2 choices that I really liked. And one was actually in the GI cancer clinic, and one was in the myeloma amyloid clinic. And a sequence of odd events ultimately led me to choose the amyloid myeloma, and honestly, it was the best. Better to be lucky than good sometimes, because my mentor there was in Boston, was just the greatest. And I saw a couple of 100 cases in my first year with him, and so that's where it all started. It's a fascinating disease, and it's a disease where if you know what's up, you can make a real difference. And so those things were very appealing. And again, not to get technical, but there's all sorts of unusual things associated with myeloma and amyloid that are highly interesting medically.
What is the connection between carpal tunnel and amyloid?
So again, so carpal tunnel common, amyloid very uncommon, but amyloid is a deposition disease where you get the waxy protein and it gets put in the heart. The carpal tunnel is a space with not a lot of room. We have a membrane around the carpal tunnel. you have some ligaments that go through it, and you have a nerve that goes through it. So if you're getting deposition of waxy amyloid proteins well before your heart's gonna let you know that it's there, it fills up that space a little bit, it gets tight, and then you get some carpal tunnel. Again, carpal tunnel does not mean amyloidosis at all, okay? At all. But it is a place to screen because I believe that we'll see more amyloid in that population than we will in people just walking into the mall. And it comes early because it's it's the first spot. When it happens there, it heralds the disease sometimes by a year or longer. So it gives you a lot of time to do a lot of new things.
Thank you.